Ladies and gentlemen, faculty, students, alumni, and staff, a very warm welcome again at the conversations today. Today, we're very pleased to have our last session of the series and extend a very warm welcome to all of you. Greetings, London, and Assalamu alaikum. It's an amazing weather out there. It's raining, and Karachi is very beautiful at this hour. So, before I introduce our speaker to you, I have a couple of thank yous to make. I would like to take this opportunity to thank each and every one of our speakers. And it actually seemed like a very daunting task to begin with, but it went in very seamlessly. And I want to thank the Department of Pediatrics and Childhood for their utmost support. A very special thanks to our administrative colleague, Mr. Arif Mehboob, and our communication team and conference secretariat. Do join us for a closing ceremony at the end. We just want to express a token of gratitude to all our speakers. For today's session, you can email me your questions at pccmpark1@gmail.com. And now it gives me great privilege to introduce our speaker. We have Professor Michael Levin joining us from Imperial College, London today, and he shall be sharing his thoughts on multi-system inflammatory syndrome in children. So let's hear it out from Professor Levin. Thank you again, sir, for joining us today.
Thanks very much, Sidra, for the introduction, and thanks very much for the invitation to join you. I'll just share my screen. Is that now visible?
Yes.
Good. Okay. Well, hello, everyone. And again, thanks for the invitation. It's a remarkable world we're in when I can be sitting in London and talking to people in Pakistan. And I think the pandemic has really shown how connected we all are and the amazing technology that lets this happen. So the past few months have been an amazing journey in being faced with a new challenge of the COVID-19 pandemic, but also the emergence of a new childhood syndrome. And I've begun the talk with this image, which I used in the New England Journal editorial that was published this last month to illustrate the complexity of the disease, and the image of the parable of the blind men feeling the elephant and each feeling a different part of the elephant's body and concluding that it's a different animal is very much like what has happened over the last few months with the emergence of the childhood multisystem inflammatory syndrome, because it has presented in different ways to different people, and we've been all grappling to try and work out what this new disease actually is. So if we go back to March and April, as the COVID pandemic started to emerge in UK and in Europe, we pediatricians in London and in other parts of the Europe and UK had all thought that what we would expect to find is what was reported from China, and the reports from Wuhan Children's Hospital and from the other centers in China were that children had mild disease from COVID. Most had asymptomatic disease, and where disease did occur, it was largely a respiratory and febrile illness, but not causing the very severe illness, critical illness and inflammation that was being seen in adults. And the graph on the slide just shows the initial reports in the UK, the age distribution of hospitalized patients, and what we can see is, as we'd expected in the early months of the pandemic, there were very few hospital admissions of children and very few that were seriously ill, and no deaths. And this was borne out in the report of the first few months, where most children just had fever and cough. There were some that had respiratory symptoms, but on the whole, they were not ill, and very few children needed intensive care admission. And those that did were generally children with underlying immune problems or with chronic lung diseases. And then in March of this year, we started to see children admitted to the pediatric wards and the intensive care units who did not look like an illness that we had seen before. They had a range of presenting features with prolonged fever, sore throat, headache, abdominal pain, vomiting. Many had rash and conjunctivitis, and some developed shock. And the shock was unusual in that it was profound cardiogenic shock. It was often associated with marked elevation of troponins and BNP levels, and with a very intense inflammatory response with raised CRP, raised neutrophils, low lymphocytes, elevated D-dimers. Some of the patients had features of typical Kawasaki disease, and the majority were negative on PCR testing for SARS-CoV-2. And by the beginning of April, we were worried that we were seeing a new disorder that didn't fit the usual patterns of childhood illness. And having reviewed the cases within London, a case definition was developed to alert pediatricians in the UK that we may be seeing a new disorder. And so the UK's National Health Service issued an alert on the 24th of April, suggesting that there was a disease causing shock, sometimes with features of Kawasaki disease, but which did not look like the usual causes of bacterial sepsis, staphylococcal or streptococcal toxic shock syndromes. We started to hear reports from other centres in the UK. Most of the large centres that were seeing large numbers of COVID started to report this disorder. So the UK Royal College of Physicians and Child Health issued an alert with a case definition for the disorder, which in the UK was called the Paediatric Inflammatory Multisystem Syndrome. A short while after the UK definition was issued on the 27th of April, the American CDC issued a definition for a disorder that they called the Multisystem Inflammatory Syndrome in Children, or MIS-C. And the case definitions were largely overlapping. They were looking for children with multi-organ failure, with rash, with conjunctival injection, for which no alternative diagnosis was found. The UK definition said SARS-CoV-2 PCR testing may be positive or negative, and antibody testing may be positive or negative. The CDC definition suggested that you had to have evidence of positive SARS-CoV-2 serology or PCR or exposure. But exposure is quite a difficult term in the middle of a pandemic when the vast majority of children have asymptomatic disease, and understanding exposure is therefore very difficult. And then the World Health Organization issued its own definition of the disorder, again, including patients with 2 or more of rash, conjunctival injection, mucous membrane involvement, shock or hypertension, myocardial involvement, coagulopathy, and gastrointestinal problems. And again, they suggested that patients should be either PCR positive, antibody positive, or having a contact with COVID. In order to try and understand how helpful the feature of PCR positive for COVID or antibody positive is, we compared the patients in our UK series, which was published in JAMA a few weeks ago, looking at the difference between patients who had the evidence of COVID-19 positivity, either with PCR or antibody testing, or were negative. And essentially, there was no difference in any of the measurable laboratory or clinical features between the people who were PCR positive and antibody positive and those that were negative. While the UK was becoming more aware of the problem, simultaneously, there were reports from Italy, from other parts of the UK, from Spain and from France, either of a Kawasaki-like disorder or of patients with shock and myocarditis. So simultaneously, virtually all the countries that were being hard hit by COVID-19 were experiencing upsurges of unusual critical care illness or Kawasaki disease. One of the clues to what might be happening is shown on this graph, which is in red, the new cases of the pediatric inflammatory disease emerging, and in blue, the PCR testing for COVID-19 in London. And it looked to us that the new disorder, the inflammatory disorder, was occurring approximately a month after the epidemic curve. A review of all intensive care admissions to UK hospitals, which was recently published in The Lancet, showed that there was a genuine upsurge of critically ill children occurring in April and May. And what the blue line is the expected number of children with shock, with Kawasaki disease-like shock, with macrophage activation syndromes that were seen in UK intensive care units in the previous 5 years. And the green line is the cumulative cases of children with the shock Kawasaki disease-like syndrome or macrophage activation. So we seem to be seeing a genuine upsurge relative to what was expected. The epidemiology was very similar in France, where we had the peak of the COVID positivity, and then about 4 weeks later, the appearance of either probable or possible cases of the inflammatory disease. And again, as in the UK and France, it was largely occurring at the centers which were experiencing the largest numbers of hospitalizations from COVID-19. Very careful epidemiology in several parts of Europe have shown that as the COVID-19 outbreak emerged, there was an upsurge of patients with typical features of Kawasaki disease. And this is data recently published from the French group and showing this huge rise in typical Kawasaki disease patients occurring coincident with the COVID-19 outbreak. And interestingly, they also saw a similar upsurge in cases during the H1N1 outbreak. The recently published data from the United States has shown something very similar. This is data from New York, recently published online in the New England Journal. And I think this is one of the most helpful epidemiological studies because New York had a mandatory reporting system, mandating reporting of patients with unusual syndromes. So they had comprehensive data on the number of cases of both COVID-19 in children and in red of the pediatric inflammatory disease occurring in all New York hospitals. And this showed the rise in number of COVID cases and then approximately a month later, the appearance of the inflammatory disease. And I think this is extremely helpful data in understanding how common or how rare the pediatric inflammatory disease is, because if you look on this axis is the number of cases of pediatric patients who were SARS-CoV-2 positive, and you can see the axis is in hundreds, so 400 at the peak, 500 at the peak, whereas on the right-hand axis, it's the number of patients with pediatric inflammatory disease, which is in tens rather than hundreds. So we have about a 400-fold excess of SARS-CoV-2 positive children diagnosed in New York to one patient with the inflammatory disease. So it looks like it is a rare complication or a rare, somehow related to the pandemic, but it gives us some feel of the numbers of the two disorders. And very similar data in the same issue of the New England Journal, now online, showing the rise in numbers of inflammatory disease cases approximately a month after the SARS-CoV-2 activity, and this was data from across multiple centers, 26 states in the United States, and 186 patients with the inflammatory disorder. Another interesting and perhaps troubling epidemiological feature of the emerging new disease is that it seemed to preferentially affect ethnic groups. And this is data from the UK, just showing that patients with a Black Afro-Caribbean background and those with East and South Asian origin were overrepresented. So this bar in red shows the expected percentage of the population of England, the percentage population of London, and we can see the vast increase in people with Black or Afro-Caribbean ethnic origins. And similarly, although London has a skewed distribution of Asian origin, there were more patients with the inflammatory disease. And concurrently, there are fewer Caucasian origin white patients. So coming to the clinical presentation, and description is based on the first 58 patients that we reported in the JAMA a few weeks ago with Liz Whittaker as the first author. And it reflects the experience largely of London and the south of the UK. But as you will see, the data is remarkably similar from other centers in Europe and from the United States. So 50% of the patients presented with shock and profound myocardial involvement. About half the patients had rash, conjunctival injection, and some had mucous membrane involvement. A surprising feature relative to typical Kawasaki disease is the high proportion of patients presenting with abdominal symptoms of abdominal pain, vomiting, diarrhea. And we had a number of children actually presenting to the pediatric surgeons with what looked like an acute abdomen, including 2 children who underwent laparotomy because the suspicion of an acute abdomen, and yet were found to have simply distended bowel and lymphadenitis within the bowel. About a third of patients had impaired renal function with elevated creatinines. And unlike adults with COVID, the respiratory symptoms were relatively mild and were not a major part of the disease, whereas respiratory illness so much predominates at the adult disease. Our analysis of these patients identified 3 main groups. There were a group presenting with shock and severe myocardial involvement. There were a group with typical Kawasaki disease, meeting all the characteristic diagnostic features with rash, mucous membrane involvement, conjunctival injection, peripheral edema. And then there were a group who were not critically ill, who didn't meet the definitions of Kawasaki disease, but had persistent fever and striking elevation of inflammatory markers. The inflammatory component of the disease is really quite remarkable. The elevation of CRP is extremely high. There were also elevation, of ferritin and D dimers. There was marked anemia and low lymphocyte counts, and there was a profound elevation of troponin and pro-BNP. So we seem to be seeing a disease which had fever, rash, conjunctivitis, diarrhea, with shock myocardial abnormalities, ECG abnormalities. About 10% of the patients had coronary artery dilatation, many had bowel inflammation, and then they had the striking laboratory features. But in the UK series, the vast majority were PCR negative, so about 20 to 30% of patients were positive for SARS-CoV-2. The majority were tested for IgG antibodies once testing became available, and most are positive for antibody. The radiological features of the disease was that some patients had normal X-rays, many had patchy consolidation or focal consolidation, and the few patients that had CT scans often had ground glass appearances similar to that reported in adults with COVID. On abdominal imaging, many patients had bowel inflammation, lymphadenopathy, and free fluid. The cardiac findings were really a prominent feature of the illness. 10% of patients had coronary dilatation, and a smaller proportion had giant aneurysms. This was one of the patients in our, early on in the study who had clear giant coronary artery aneurysms. And in addition, many patients had pericardial effusions, had impaired left ventricular function, and a number of patients had quite marked arrhythmia, one of the patients actually requiring extracorporeal membrane oxygenation because of persistent arrhythmia. So the three different phenotypes are really a problem, and I'll come to that, because we have this group of patients who simply have fever and inflammation. Some of them also had one or two of the features of Kawasaki disease, but they did not meet the diagnosis of Kawasaki disease, but some of them still went on to have coronary artery aneurysms. Then there's the group presenting to intensive care who are shocked, many presenting with abdominal features, some of them having the features of Kawasaki disease, and many of them developing coronary artery dilatation or aneurysms. And then they're the group that met all the classical features of Kawasaki disease. This pattern of some patients having significant inflammation, some meeting the diagnostic criteria for Kawasaki disease, and some presenting with shock and multi-organ failure, was also seen in the two recent reports from the United States, where there was a mixture of patients with dermatological and mucocutaneous features, gastrointestinal presentation. In their series, about half with Kawasaki disease or typical Kawasaki-like features, and some patients presenting with myocarditis or neurological involvement. So what I've tried to describe is this gradually emerging picture of COVID being generally mild, and then this spectrum of illness, with the tip of the iceberg being the MIS-C, or the Paediatric Inflammatory Multisystem Syndrome, which presenting with shock and multi-organ failure. Then a group of patients with Kawasaki disease-like appearance, and then perhaps a bigger number of patients with fever and inflammation. And I think this comes back to the analogy I used at the start, that what is this disease, and how are these different manifestations of it connected? What is the relationship to Kawasaki disease? Is it a macrophage activation-like disease? It looks very like staphylococcal toxic shock syndrome. It has features of macrophage activation syndrome. So what is it that we're actually dealing with? And in order to try and unravel how this disease differs from the things that we know about, we undertook a comparison of the patients with pediatric inflammatory disease, shown in red, with children with classical Kawasaki disease in the pre-COVID era, with patients with Kawasaki disease shock syndrome, and with the staphylococcal toxic shock syndrome. And we were very fortunate in that we've had a very long collaboration between Imperial College and Jane Burns's group in San Diego, who's one of the leading Kawasaki disease research groups in the United States. And I contacted Jane Burns and asked if she would share her data on 1,000 children with Kawasaki disease that she had collected data on over the previous years. And one day after making the request, she shared her entire database of Kawasaki and Kawasaki shock syndrome. And I think it's been a remarkable thing of how well pediatricians in different countries have collaborated to try and understand the new disease. So what this set of rather complex plots shows is the comparison of the new inflammatory disease with Kawasaki disease shock syndrome, and staphylococcal toxic shock syndrome. And what you can see is that the pediatric inflammatory disease are older than classical Kawasaki disease. They have higher white cell counts. They have higher neutrophil counts. They have a striking depression of lymphocyte count compared to the other diseases. Their hemoglobins are lower than Kawasaki or Kawasaki shock. Their platelet counts are lower than Kawasaki or Kawasaki shock. They have strikingly higher CRP levels, some of them going up to extreme elevations of CRP. Many of them have abnormal liver function testing. They have lower albumins than Kawasaki or Kawasaki shock syndrome. They have higher ferritin levels, and they have higher troponin levels and D-dimers than either Kawasaki or Kawasaki shock syndrome. So I think this analysis, which was published a few weeks ago in JAMA, really suggests that although this disease looks very much like Kawasaki disease, it has important differences in both the laboratory findings and the age, and also the ethnicity of affected patients. So the big questions that I think we're grappling with as we become familiar with this new disease is, how do these different spectrums of the disease relate to each other? We have the mildly ill children with symptomatic COVID. Then we have the children who are presenting with inflammation, extremely high CRP levels. We obviously look very hard for bacterial infection, and these children remain febrile with high CRP or white cell counts. Some of them have features of Kawasaki disease, and then a smaller proportion have shock and multi-organ failure. And what the experience of those patients reported in our JAMA paper was that coronary artery dilatation and aneurysms were seen in all three groups. So the children who just had fever and elevated inflammatory markers, a small proportion developed aneurysms, a proportion of the Kawasaki patients, and a proportion of the shock and multi-organ failure. So there is a worry of what should we be doing with these patients to stop developing aneurysms? And then what is the likely outcome if we don't treat children who just have fever and inflammation? Will some of them present to look like Kawasaki disease, and will some develop shock? And then I think of great importance is, what treatment will prevent this progression? Should we be treating these children to stop either the aneurysms or the progression? Are there biomarkers that will tell us which children are more worried about? And what treatments will prevent coronary artery aneurysms? And these are, I think, the main urgent management questions. And I think they're particularly questions of importance to countries that are less resourced, who may not have available immunoglobulin or biologicals and need to know what treatments work. So the urgent questions are, do patients progress from fever and inflammation to Kawasaki disease to the multisystem syndrome? What is the risk of aneurysms in each group? What is the relationship between Kawasaki disease as we knew it before COVID and Kawasaki disease as we now see it in the midst of the epidemic? Which treatments will work? And particularly, I will try and touch on what treatments should we be using in less resourced countries? What are the mechanisms of the disease? And are there biomarkers that will help us distinguish the different groups? So just showing some of our attempt to say, can we predict patients when they present to hospital with fever, with some of the features of the Kawasaki disease? do those who go on to get shock and myocardial failure differ from those who don't? And again, this is a complex slide, but I'll just highlight the shocked patients at presentation had higher CRP levels than those who never developed shock. They had higher ALT liver enzymes, they had lower albumin levels, they had higher ferritin levels, but particularly they had much higher BNP levels, they had higher troponin levels, and they had similar D-dimer levels. So if we combine the features of CRP, troponin, and BNP, the shocked group were clearly distinguished from the non-shock group, and the ROC curve, the receiver operating curve, distinguishing the two, looks very good. So it looks as if we probably can predict which patients are going to go on to get shocked by the features, the laboratory features, when they arrive in casualty department. But I should emphasize this is based on a small number of patients, and we really need to repeat it in much larger numbers. On the question is, do any of the laboratory markers distinguish patients who develop coronary artery aneurysms from those who don't? Again, a complex data set. It's from the supplement in our JAMA paper, but essentially the conclusion is we do not have any markers which predict coronary artery aneurysms. And this raises an issue of what treatments can prevent aneurysms, and why do aneurysms occur in some patients and not others. We've also tried to look at how the patients with the pediatric inflammatory disease who do have either coronary artery aneurysms or have features of the classic features of Kawasaki disease, how they differ from Kawasaki disease as we knew it pre-COVID-19. And again, a lot of data on the slide, but what we could summarize, if we just compare PIMS patients with features of Kawasaki disease or aneurysms with Kawasaki disease pre-COVID-19, there are major differences in the age of children. They're an older age group. They have higher white cell counts and neutrophil counts. They have lower lymphocyte counts, and they have higher CRP, lower albumin, higher ferritins, and higher troponin levels. So despite the similarity in clinical manifestations of PIMS-associated Kawasaki disease, the disease is, at least in its laboratory features, different from Kawasaki as we knew it before. So what is the mechanism of this disorder? And the answer is we really don't know, but there are a number of clues. Because this is occurring 1 to 4 weeks after SARS-CoV-2 infection, it would seem that we are dealing with a illness that is developing as acquired immunity is developing against SARS-CoV-2. So we would speculate that the majority of children in the population who don't get ill or have asymptomatic SARS-CoV-2 infection have what we would call the normal immune response. And then a smaller number have a different type of immune response, which results, sorry, I'm jumping around, which results in the production of either a T cell or an antibody mediated response, which rather than just protecting against the infection is somehow causing organ damage. And this results in the 3 different patterns: the febrile child who has marked elevation of inflammation, the MIS-C or PIMS-TS multi-organ failure disease, and the Kawasaki disease. And the clue that this might be mediated by an abnormal immune response perhaps comes from thinking about what we know about Kawasaki disease, and also what evidence there is from the SARS-CoV-1, the SARS epidemic of a few years ago. And in Kawasaki disease, all the genetics of Kawasaki disease suggests that genes that are involved in antibody production, the clearance of antibodies, or the speed of activation of B cells and T cells are what distinguishes the Kawasaki disease population from patients who don't get Kawasaki disease. So we would suggest that there is perhaps a genetic predisposition to produce an unusual antibody or T cell response. In the case of Kawasaki disease, we've known for many years that patients with Kawasaki disease have immune complexes in their blood. And because of the similarity to Kawasaki disease, we would suspect that there might be a genetic predisposition, perhaps involving the same genes that are involved in Kawasaki disease, such as the Fc gamma receptor 2, which is involved in clearance of antibody, that may make some children produce a different response from the majority of children. Is there evidence for antibody or immune complex mediated disease? And this paper from JCI Insight from SARS-CoV-1 suggested that antibodies against the spike protein of SARS-CoV-1 trigger IL-6 production and macrophage activation. And of interest is just this last week, a paper has appeared in bioRxiv from a Dutch group, which shows very similarly that antibodies against SARS-CoV-2 spike protein, when in combination with the target antigen, trigger IL-8 activation and IL-6 and a whole slew of inflammatory mediators when this immune complex is present. The IL-6 may be very relevant because we previously showed and studied on meningococcal shock that IL-6 is the mediator of myocardial dysfunction in septic shock and meningococcal disease, and the extremely high CRP levels and high IL-6 levels in the PIMS patients suggest that we may be seeing the same thing in this disorder. So coming to what treatments we should be thinking of. So as the illness began to be recognized in Europe, pediatricians tried whatever they thought might work. Those that thought the disease looked like Kawasaki disease gave intravenous immunoglobulin. Those that thought the disease looked like macrophage activation syndrome, or perhaps looked more like staphylococcal toxic shock syndrome, gave steroids to some of the patients, while the rheumatologists often gave drugs that worked in other inflammatory disease, such as anti-TNF or anti-IL-1 or anti-IL-6 strategies. And in this review of 134 patients from across Europe, which Prof. Elaine Freys at the Royal Brompton Hospital provided, showed that immunoglobulin was the commonly used treatment, but steroids, anakinra, and infliximab were also used. In the recently published study of the experience of UK pediatric intensive care units, this slide just shows the change in treatment strategy as understanding of the disease evolved. So in early May, when people started seeing it, the red line shows the use of intravenous immunoglobulin. So the early patients in early April were not receiving immunoglobulin. Steroids started to be used in some of the patients, and then the use of steroids increased, the use of antiplatelet agents, and similarly the use of biologicals all increased as people began to think this is more like Kawasaki disease or like macrophage activation syndrome. But I should say that of the patients treated during April and May, about a quarter of them did not receive either immunoglobulin or steroids or a biological. So there were patients that were improving just with good intensive care support. So trying to answer the question of what treatments should be used, and particularly what treatments should be used in countries where immunoglobulin and biological agents such as infliximab or tocilizumab are not readily available is an extremely difficult question, because we really have not got any data from randomized trials. And it's because of this that our group at Imperial has established an international study to try and address the question of what is the best available treatment. And the team likes to refer to it as the Do Your Best study. And clearly we need randomized trials, but the pandemic has evolved too quickly for the trials to be established. People are facing the disease now, particularly now in South America, in Africa, in Asia. So we don't have the data from trials. It's going to take time to set up randomized trials. And over 1,000 children have already been treated across Europe and the United States, with clinicians doing their best guess as to what treatment to give. Many countries have a shortage or no availability of immunoglobulin or biologicals. And what the study is aiming to do is to use the data on already treated patients and those who are presenting now to work out what treatment works. And the hypothesis in this study is that although we're not able to randomize patients, in fact, there is a sort of randomization, because patients are being treated either by the physician preference or the belief system of each physician. So the Kawasaki disease people who think it's Kawasaki disease will give immunoglobulin. Those that think it's more like staphylococcal toxic shock may give steroids and antibiotics. And so although we haven't randomized in the true sense of a randomized controlled trial, there is randomization both by physician's preference and also by the availability of therapeutic agents. And if we can enter patients and large numbers of patients onto a common database, we can compare the rate of improvement of inflammatory markers and the coronary and cardiac and intensive care outcomes. And this is just a speculating curve of, if we look at how CRP level may change between patients who didn't receive immunoglobulin or steroids and those that received IVIG or steroids or biologicals, we ought to be able to work out which patients work, really because the statistical methods to match patients for severity and to correct for unequal differences in severity at presentation are now very well established. And there have been a number of recent high impact papers not using randomized trials, but using propensity matching to compare the patients. So we are really requesting patients all over the world to join the study. It's open to every country. Because it doesn't require individual patient data, there are no real ethics concerns. The patients are enrolled only by the referring clinician and by their study site, and there is no patient identifiable details. And the study is open by a web-based enrollment to countries all over the world. And we hope that by putting in the electronically captured data, a machine learning and statistical modeling group at Imperial College will be able to work out whether patients treated, say, with steroids, which we know are readily available in many countries, that don't have access to immunoglobulin and biologicals. We are hoping that we will be able to say whether steroids are just as good or not as good as treatment with other agents. And this is a study which we hope will be genuinely international and collaborative. Everyone who enrolls patients in the study will be listed as a member of the study group, and it's open to all countries in the world. So we just urge people, log on to this database and you can enroll your patients. And we also need to understand the biology of this disease. And like all new and evolving diseases, often it's very hard to recruit patients into clinical trials and to have samples available to do the research. Within Europe, we were fortunate that just as the pandemic evolved, the European Union awarded a very large grant for collaboration between our group at Imperial and multiple centers in the UK and Europe. And so patients are being enrolled in studies, and their samples of DNA, plasma, and serum are being collected, as well as their data. And we hope that this will help us to understand the disease. So I will conclude by saying it's really remarkable that in just a few months since the first cases, there are now such an extensive published literature describing the disease. And the data has come from many countries now, so we have a good description of what the disease looks like. The pace at which the data has been gathered and published has been quite remarkable, and really the pandemic has brought together pediatricians from many hospitals in many countries in collaboration to understand these diseases. We need international collaboration and sharing of experience and expertise and data. And really the pandemic has highlighted how connected we are as clinicians and researchers, and how by pooling expertise and pooling data, and hopefully in the future pooling samples for research studies, we'll be able to understand the disease in more detail. So I'd like to end by saying that the data I've presented has been gathered by a very large group of pediatricians with collaborators in many countries. And I just want to thank all the members of our group at Imperial, the other pediatricians across the UK and Europe, our collaborators, Jane Burns in San Diego and others in Europe, and the team who are running the BATS study, the Best Available Treatment Study at Imperial, and really the support we've had from the UK NHS in bringing this disorder to attention. So thanks very much for listening, and I'm very happy to take questions and also share experience. And thanks again for the opportunity to talk. It's really been remarkable that we've been having communications about this disease with pediatricians in many countries in a way that would not have been possible without the web links and the sort of data sharing that we're now having to do. So thanks again for the opportunity to talk to you, and I'm very happy to take questions.
Thank you so much, Dr. Levin, for your time and sharing your knowledge with us. It was indeed an honor to have you here with us. And thank you once again. I think it was a fantastic presentation and covered almost every aspect of PIMS-T and multisystem inflammatory syndrome. So if you allow, we'll proceed towards some questions that we have from our participants.
No.
Okay. Just a second. All right, so our first question that we have is, with regards to the dose of steroids and the choice of steroids. Like we've been using methylprednisolone in our setting, but then there has been data that shows this dexamethasone is there, but it was mainly from the adult world. So is there any specific dose with regards to pulse dosing and specific presentation as to what dose to prefer over one and the other?
Thanks. Very difficult question, and one that would have to preface the answer by saying the answer is a complete guess, because the real answer is that we don't know. So like almost all use of steroids in many, many different conditions, no one really knows what the best dose is. The doses used in the UK experience and in much of Europe was either borrowed from the Kawasaki literature. So in Kawasaki disease, I suppose the major evidence we have, it comes from the Japanese RAISE study, which was published in the Lancet a couple of years ago. And that study really compared combining steroids with immunoglobulin in primary treatment of Kawasaki disease. And they used a relatively low dose of steroids. So it's equivalent to 0.8 milligrams per kilogram of methylprednisolone or 2 milligrams per kilogram of prednisolone, so quite modest dose. The other literature on Kawasaki disease has used pulses of methylpred as high as 30 milligrams per kilogram, but that wasn't shown to have a lessening effect on coronary artery aneurysms. I have to say that practice is being completely based on physician preference without any real data. And I think our own group has steered somewhere between the Kawasaki literature of 2 per kilo and higher doses in patients who look as if they're developing shock. So those patients that look as if they're heading towards intensive care unit have often been given 10 milligrams per kilogram of methylprednisolone on 2 or 3 days, and then a smaller dose of oral steroid. But looking at the data across Europe and the United Kingdom, there really isn't a preferred dose. And people have used prednisolone orally, people have used, for not very sick patients, they've given intravenous methylprednisolone following the RAISE data of 0.8 per kilogram, and others have given 10 per kilo or 30 per kilo in very, very sick patients. So this is really what the BAT study will try and answer. If we had patients all over the world enrolling their patients, we would know whether dexamethasone is any different from prednisolone or methylprednisolone. So again, I can't answer your question other than saying there's a wide range used. The adult study, the recovery trial, which has suggested dexamethasone is beneficial. Was it in a population of patients ventilated for severe respiratory disease, and how relevant that is to PIMS or MIS-C, we don't know. I think I haven't mentioned it in the talk, but we are struck by how similar the laboratory features are of the pediatric inflammatory disease to what adults are seeing in the inflammatory phase of COVID, in that the levels of CRP, ferritin, D-dimers are all very similar, looking as if the inflammatory disease we're seeing in children is the same as the inflammatory disease in adults, only it's occurring at a different stage of the illness. So in the adult disease, it seems to be occurring on day 7 to 10 of hospitalization, whereas in children, it's occurring usually after they've cleared the virus. And obviously, we may, if dexamethasone has worked, it's likely to be working in PIMS as well. So I'm really answering the question by saying we don't know what dose or which type of steroids to use. I think probably people should use the steroid that they're familiar with and understand the side effects and the complications best. But really, if we can get patients into the BAT study, we will quickly be able to answer this, particularly because Europe, the UK, and the United States are now giving virtually all the patients immunoglobulin because they think that it's unethical to withhold immunoglobulin if you think it might be Kawasaki disease. Whereas countries that don't have immunoglobulin available or biologicals who are now experiencing high numbers of cases will have steroids available. And we can therefore do a comparison between countries that are using immunoglobulin and countries that are using steroids. And we may find that they both do exactly the same, which would be reassuring for people in countries that don't have the same availability of biologicals or immunoglobulin. So I'd really urge colleagues in Pakistan to join the BAT study. We would love you to be part of it. And we would then almost have a randomization by availability between the countries that are using steroids and the countries that are using immunoglobulin.
Thank you so much, Professor Levin. I think that answers most of the questions put here. So I absolutely agree. It's a novel disease, and everybody, we're learning something new each day. So there may be just no right or wrong answer to what treatments exist today. But yes, I think being part of a collaborative project and maintaining registries may be the right way to go. So I think point well taken there. Another question is that most of the studies that you shared, those were published in JAMA and Lancet, did not report mortality benefits. So if we were to talk about steroids versus immunoglobulins versus biologicals, and just look at the availability given a resource-limited setting like ours, so what do you suggest? Like, since there's no mortality benefits, so maybe we don't know, like, whether giving or not giving actually has an impact. So how do you suggest, like, what's your take on that?
Yeah, thanks. Again, a very, very important question. When the first cases were seen during March and April, our impression was that we were seeing much sicker children because they were presenting much later and being treated later. And that may have been partly because of lockdown. The public health advice was don't go to hospital if you had a fever, stay at home and take antipyretics. And so some of the children presented critically ill, and the deaths that we had, and we had a number of children requiring extracorporeal membrane oxygenation, and we had a number of children dying. Since the disease has been more widely recognized, and the public health message has been, if you have symptoms suggestive of this disorder, do come to hospital and be tested. We think we are seeing patients earlier, and we are starting them on treatments with agents to switch off the inflammation earlier. And so the general experience have been no further deaths, or we've had death of a Kawasaki-like patient from a ruptured coronary artery aneurysm and thrombosis of coronary artery aneurysms. But the deaths from myocardial failure and shock seem to have stopped with earlier treatment. So I think in terms of doing a trial, we won't be able to use death as an endpoint because there simply are not enough deaths to be a comparator. And that's why I think the endpoints would be number of patients developing coronary artery aneurysms, which is with round about 10% being the number that we have with treatment. We don't know how many we would have without treatments, but it's a sizable number. So coronary artery aneurysm dilatation as an endpoint, days of intensive care and inotrope use, and the proportion of patients requiring intensive care. Because again, our impression is that earlier treatment stops progression to intensive care. In the UK, there was such an alarm in the early weeks of the disorder that it was suggested that all children had to go to a center that could offer extracorporeal membrane oxygenation, which are very few in the UK and even fewer elsewhere. And we quickly realized that patients were switching off with treatment, and therefore it was fine to have them go to an intensive care unit at a local hospital that didn't have ECMO because the need for ECMO didn't seem to be there. So I think progression to intensive care, and then because we've got such good biomarkers of the cardiac injury and the level of inflammation, we can do a study on which treatment results in most rapid resolution of cardiac injury in terms of troponin and BNP, and which agents result in most rapid resolution of inflammation. So it's really resolution of inflammation, days of intensive care, requirement from intensive care, and coronary artery aneurysms that will provide outputs that we can compare in the BAT study.
Thank you for that response, Professor Levin. Another question is with regards to the strong IgG response. Like, a lot of our patients are suspected COVIDs and they present with multi-inflammatory system-like disease, but they're turning out to be PCR negatives. So we have a very limited resource in doing quantitative immunoglobulins right now, but we've started doing that. So do you suggest, or how do you see doing the role of serology as an important biomarker if you're talking about therapeutics and management?
Thanks again. Again, all the questions we've struggled with. So like you, in the early weeks of the recognition of the syndrome, we didn't have antibody testing available. So all we knew is that they were, 2/3 of them were negative by PCR. And we first thought the PCR must be wrong. And we did it over and over and over again, and it was still negative. So we're pretty sure that this is an illness occurring after the virus has gone. As antibody testing became available and has got better, we think the majority of patients are antibody positive, but not all. And we also are hearing reports from Canada and the United States of antibody negative patients. And we don't know whether that's because the antibody tests are no good, or because the patients haven't yet developed antibodies that are, if the antibodies are binding to the heart or to the other tissues, you may have significant amount of antibody-mediated disease before there's free antibody in the plasma. These are research questions. So and the other thing is the available antibody tests really only measure spike protein or membrane, one or two of the proteins. The virus has 25 proteins, and it may be that some people produce a response to one protein and not another. And so I think really we need the research. And if you are seeing these patients, save serum from them, save plasma and DNA. If you don't have a research program looking at the disease, we would be, and other groups around the world would be very happy to collaborate and try and work out what this disease is. So I think absolutely it's a new problem to work out, and if you can save the biological samples, RNA, plasma, DNA, there will be people around the world who would love to collaborate with you. So I think the only way that we're going to know how to treat the disease or how to prevent it is to do the research. And there's maybe even a more serious and important reason that we have to understand this disease. And that if it is as we think it is, that it's an unusual immune response to some of the viral proteins, then there's a real danger that a vaccine may do the same thing. So if this disease is mediated by antibodies against the spike protein that somehow cross-react with the heart, if we start giving vaccine based on spike protein to the whole population, a proportion may get this problem. And that would set back vaccine development enormously. So we think there's a real urgency to understand the immunology of this disorder, not only so we understand MIS-C or PIMS, but for what it might tell us about adult COVID and vaccines. So be delighted to collaborate if your center can save samples, and I think there's a big effort to share samples and share expertise in the research side as well.
Yeah, I think that's an excellent point there. Initially, we were of the view that we would rather need just fresh samples on most of the analysis, but if we can have them stored and, come up with something that may actually help our patients, so nothing better. So thank you for that. So we have another 5 minutes to take 2 more questions, if you allow. Okay, so another question is with regards to role of anticoagulation in our pediatric population. This is something that's been just coming up. We don't have a lot of established data on this. So what's your take on that?
Well, I think the first thing to say is that we're also very worried because we have had children develop major large vessel thromboses. And one child who has actually had very extensive thrombosis. The adult experience of the inflammatory disease in adults is that a high proportion are getting emboli and thrombotic disease everywhere. And the extremely high D-dimers, and the patients also have very high fibrinogens. So it looks like they're in a very hypercoagulable state. It's quite a puzzling finding to have both high D-dimers and high fibrinogen, because it suggests that something is wrong with plasminogen activation and with thrombolysis. So I think without exception, the UK intensivists are now putting patients on low molecular weight heparin or heparin as prophylaxis if they're very ill. And those that look more like Kawasaki disease are getting aspirin. And those that look very sick and have Kawasaki features are getting both aspirin and low molecular weight heparin. So I think anticoagulation seems to have become standard practice, again, based on a fear and the experience of patients who have clotted and on the laboratory findings rather than on any published data that on the true risk of thrombosis. But I think there's no doubt that there is a risk of thrombosis, and they do seem to be hypercoagulable.
Right, and thank you so much for that response, Professor Levin. Just one last question is, so there's this entire array of testing that goes in whenever there's a patient who comes in as suspected COVID or confirmed COVID. So any like if you were to name any 3 or 5 tests that we could actually follow as a trend, or probably come up with a panel for resource-limited centers, so what would be your suggestion?
Thanks again. You're asking all the difficult questions we've been struggling with. I think from the perspective of the accident and emergency department or the emergency department that's first seeing these patients, the first question is, are they dealing with bacterial sepsis or are they dealing with an inflammatory disease? And all of the laboratory tests don't distinguish. So the high CRP, the high white count, even the severe lymphopenia, we've thought that severe lymphopenia is a good predictor, but we've also seen severe lymphopenia in patients with gram-negative sepsis and with staphylococcal and pneumococcal septicemia. So the inflammatory markers of CRP, white count, lymphopenia, low albumin are all overlapping with bacterial infection and don't help us distinguish. And also, so the cardiac markers we think are helpful in predicting progression to myocardial failure and injury. So the troponin levels look very helpful. But having said that, we have seen high troponins in sepsis and septic shock. And in fact, we're just busy trying to do the study now to ask, are the troponins in PIMS discriminatory compared with patients with septic shock? So I think the troponin and the proBNP are very good at alerting us that this is a patient who may progress to the severe end of the spectrum, but may not distinguish from bacterial infection. So I think our answer is at this point, while I think the best markers of use are probably the CRP, the lymphopenia, the troponin, the proBNP or BNP, and the ferritin levels, because the ferritins do seem to be higher in the PIMS patients than in most septic patients and in Kawasaki disease. So I think if you are limited in resource, I think you get the lymphopenia and the neutrophil count on routine blood count. The CRP is a pretty standard and useful marker pointing you that this might be within the spectrum. And then the ones that might help in distinguish it from sepsis and from Kawasaki are the ferritin, the troponin, and the proBNP.
Right. Thank you so much, Professor Levin. We are slightly over an hour. We have a few more questions that we'll try and email them to you. And if you could possibly have this answer, so we'll take them from the audience.
Okay.
So now I would once again like to thank all our speakers. We have quite a few join us for the closing ceremony. I would like to invite my departmental chair, Dr. Salman Kirmani, to say a word of thanks and express his gratitude to all of us.
Hi, everyone. Thank you so much, for doing this for us. This has just been a phenomenal series. I've been following in and out. I'm sorry I haven't been able to attend all the lectures, but the fact that people have been so generous with their time and really, an international effort to help increase the knowledge, help increase the capacity in our country, and help our people, help our providers is really very much, we're very, very thankful for all your efforts. Specifically, I'd like to reach out to Mike, Arun, Sebastian, Vinay, Todd, Arun, Martin, Sujata, Akash, Sapna. I think all of you individuals have really been phenomenal, and I think you're going to remain partners and collaborators in this effort. This is something that we're going to, as you have all mentioned, going to fight together, and we will certainly lean on you for help. And we hope that with the collaboration, what you learn from our end can certainly help your patients as well. So thank you once again for coming together and doing this. And thank you to Sidra and her team for making this all possible.
Thank you so much, Dr. Salman. Thank you. So we would like to close our session now. It was indeed a great learning experience for all of us, having the best of pediatric critical care share their ideas and knowledge with us. So thank you once again, and we look forward to meeting you someday in person at any conference. Thank you. Take care. Good evening.
Thank you, and thanks for the invitation.
Thank you so much, Professor Levin.
Thank you.